Women's health is often discussed as a series of separate issues. In reality, it's a lifelong journey with different risks, conditions, and health needs emerging at different stages. Many of these changes also intersect with working life, shaping how women experience their careers, well-being, and long-term health. Recent analysis of official statistics show that the number of women who are economically inactive due to poor health rose by 48% between 2018 and 2023. Within this, sickness absence linked to musculoskeletal conditions has increased by 47%, cancer-related absence by 15%, depression, anxiety, and other mental health conditions by 27%. These trends point to a growing and tangible connection between women's health and workforce participation. At the same time, women's health remains an area where misinformation is increasingly widespread, particularly through social media and AI-driven health advice. Many conditions are also frequently misdiagnosed or underdiagnosed, and historically, women have been underrepresented in clinical trials and medical research. As a result, women may struggle to access clear information, timely diagnosis, and appropriate care. For organizations, this presents both a challenge and an opportunity by improving awareness, supporting access to care, and creating more open conversations around health. Employers can play an important role in helping women better manage their health across their working lives. Today's session will explore the life cycle of women's health, including gynecological health, hormonal change, and cardiovascular risk, from early warning signs through to long-term health risks, and what both individuals and organizations should understand to support better outcomes. Now, I'd like to hand over to our panel of distinguished guests to introduce themselves, starting with Dr. Jane Benjamin.
Thank you. So I am the Women's Health Lead at HCA Primary Care, and I do a combination of GP, health screening, occupational health, and a lot of corporate health and wellness. So I see women through various different lenses and often need to refer them on to my colleagues. And I'm just so grateful for the network that we have.
I'm Shrilla Banerjee, as you said. I'm a HCA cardiologist and also work in the NHS. My main interests are basically women's heart health and also coronary artery disease, both the prevention of it and also the treatment of it.
Thank you.
I'm Sushma, Srikrishna. I'm a consultant gynaecologist. I'm subspecialist urogynaecologist, and I also deal with menopause healthcare. I too work in HCA, side by side by the wonderful colleagues on the sofa, and I also have an NHS practice in King's College Hospital.
Wonderful. This discussion will primarily focus on mid-20s onwards, so the core working years. And however, many women's health conditions that show up later in life actually start much earlier. So Jane, I'll start with you. What role do contraception and early screening play in protecting long-term health?
Thank you. So I think that's such a great question. What's so interesting about this is how individuals' thoughts around contraception has changed. When I started working in the city over 15 years ago, almost every second consultation was to discuss contraception. And I honestly can't tell you the last time I had this conversation with my patients. We know that in the UK, 45% of pregnancies are unplanned or ambivalent, with abortion rates rising above 32 years of age. Contraception is designed to prevent unwanted pregnancies, but it's such a great treatment strategy for so many other conditions. Mm-hmm. Heavy menstrual periods, it helps to regulate the cycle. It's excellent for PMS, premenstrual syndrome, or PMDD, premenstrual dysphoric disorder, which is a very severe form of PMS, where sometimes 2 weeks of your cycle you're severely affected by mood-related symptoms and sometimes suicidal thoughts. It can work brilliantly to help both these conditions. Polycystic ovaries, endometriosis, and there are just so many areas that we can use it safely. Mm-hmm. I think what's interesting is the younger generation is moving more towards getting information they need from AI or from influencers or Instagram. And we know that the information out there is don't put hormones in your body, and you shouldn't consider the oral contraceptive pill. And it's absolutely fascinating that we are seeing this in healthcare.
Thank you.
Yeah, so from my point of view, screening at an early age is actually very beneficial in identifying the silent risk factors for cardiovascular diseases that we can see in people in their 20s and onwards. So things like hypertension, high blood pressure, pre-diabetes and high cholesterol, all of which can be impacted on not only with medications but also with lifestyle interventions. And then the long-term aim would be to reduce the events, cardiovascular events that are predicted as a result of those risk factors. So it's definitely worth identifying these early and intervening early so that actually we make a woman's life longer and healthier.
Thank you.
From my perspective, I think I would go along with what Jane was saying, is if young women who need to be on the hormonal contraceptive pill actually took it at the time that they ought to be, simple things like endometriosis, for example, it's a prime example, would be suppressed so much earlier. People often think that surgery is the solution for endometriosis, but it is almost never the only thing. And yet I will have a 19-year-old who has had 4 negative laparoscopies and who would choose that over taking some hormonal suppression to stop the endometriosis from growing and only coming off it in time to conceive and then going back on the pill. These are important considerations, but thanks to Dr. Google, social influencers, it's getting harder and harder.
So what you're referring to with the interventions is that it's a much more pronounced intervention as opposed to the simplicity
Absolutely.
of taking the oral
Because there is this
contraceptive.
fear that the pill will mask something, but as long as you come to a diagnosis, then the pill isn't just used to mask it, it's an actual active and very efficient treatment of very many conditions. So I think absolutely contraception and screening are vital.
Amazing. Thank you. Thank you so much. And many of these issues start early, as we've already ascertained, but their real impact often becomes clear when women enter their late 20s, 30s, and early 40s. So for many women, this is when careers are accelerating, families are forming, and life is at its busiest. So what are the most common conditions for women during these years, and what patterns do you see in how they are recognized and how they are managed?
Again, so that's a really good question. The commonest conditions that affect women start off at this time, and then they will often persist all through their working life, as I'm sure we'll come to. I think the biggest things that I see are fibroids, polycystic ovarian syndrome, endometriosis and adenomyosis, all of which actually present at this stage with very similar symptoms. Largely they will be grouped into menstrual problems, so either you will have very heavy bleeding, often with large clots and flooding, or very painful bleeding outside the actual periods, bleeding in between periods, often then translating into ancillary symptoms like pain on intercourse, which is often very crippling. So when these all cluster together, it's really important that these are teased out because they will affect women physically, emotionally, mentally, and sexual health is affected. And when you contrast that these are very common and they occur at a time when women are trying to climb that ladder at work and they need to be there, they have a massive impact on quality of life, a massive impact on being able to turn up to go to work and not call in sick because on 2 days you cannot get out of bed. Sexual health is very important as well because that adds to the amount of stress and strain somebody is already going through. So when you add all of these three together, they lead to increased sick days, increased anxiety, mental anxiety, and affects your ability to carry out your day-to-day activities. So I think these are the commonest.
Yeah, thank you.
So we really do need to focus on our cardiovascular risk. About 20% of all heart attacks happen in the under 40s. That's men and women. So it's not something that just doesn't happen to women, and it doesn't not happen to women, younger women as well. So we really do need to focus on this area. And there are a number of other conditions. It's not just heart attacks. There are a number of other conditions that can hurt women from their cardiac status as well. So in particular, heart muscle conditions, arrhythmias, valvular heart conditions, and hypertension, high blood pressure, So these are all diagnoses that we should be seeking to exclude in our younger female population, as well as our young male population as well. And a lot of the causation is linked to lifestyle factors again. So poor diet, sedentary working lives and lifestyles, smoking and vaping, again, very important causes of heart disease in younger women in particular, and obesity and diabetes. So again, if we identify these conditions at a young age, we can act on those lifestyle factors and hopefully reduce their ongoing risk going forward.
I think that's such an interesting statistic that you said about the, such a dominant cause of death for both male and females below 40s.
Just to add to what you've said, women are always worried about breast cancer, but as a woman, we don't realise that we're about 2.5 times more likely to have a cardiovascular event than we are to develop breast cancer. So heart health is so important. But cancers, we're definitely seeing more cancers coming through, starting in younger individuals. And from a women's health perspective, this is where screening is so important. We pick up breast cancer, cervical cancer. These patients are asymptomatic. They have absolutely no symptoms. Stay up to date with your screening. Make sure that you're having your mammograms. Through company-led programs, you're able to access these services much earlier. We also need to be aware of endometrial and ovarian cancer. Ovarian cancer is one of those silent killers because symptoms present very similar to other medical conditions such as irritable bowel syndrome. You might just have some bloating and abdominal discomfort. And we often see that individuals might have presented a few times to their primary care physicians before they get an onward referral. So cancer is important. And then also the secondary effect of cancer, the physical effect of the treatment, the surgery, the chemotherapy, the radiotherapy, but then also the hormonal treatment for estrogen-sensitive cancers pushes individuals into an early menopause that then increases all the risks that we're going to speak about, including the cardiovascular risks. And we'll come on to some menopause information shortly.
Thank you, Jane. And we also have a previous episode specifically on breast cancer, so I'd really like to refer you to that for more information. So during this period, women are often, this age, women are often thinking about fertility and pregnancy. That becomes a central consideration. So what health risks during pregnancy should women and employers be aware of?
So I think in the population that we see in the city, the most common thing is delaying fertility. So we're seeing individuals moving towards egg freezing and IVF. And that egg freezing and IVF is not necessarily just one cycle. It might be numerous IVF cycles, maybe 3, 4, 5, sometimes even 10 cycles. Each cycle means time off work, huge psychological impact, huge physical impact and stress on the body. And we need to be looking as employers, how do we support those individuals going through these life stages, especially in the workplace. So I think that's really important. We know that if we delay fertility with what we're seeing, that there's an increase in cardiovascular risk. And it's important that individuals are aware to make sure that they get the right help they need in a timely manner.
Yeah, so pregnancy is, we call it a biological stress test. And it really is. It's from the moment you conceive, your body's going through quite significant changes, and cardiovascularly, you're going through quite a significant physiological stress. So it's often a time when underlying conditions are uncovered. So patients who've got cardiovascular diseases impacting on their onto their heart valves, on their heart muscle. Those conditions can become obvious. People who've got underlying blood pressure, suddenly it can become obvious because people are checking your blood pressure. And then, in addition, pregnancy can actually cause particular cardiovascular conditions or increase your cardiovascular risk going forward. So if you have conditions such as gestational diabetes, so sugar in pregnancy, high blood pressure in pregnancy, if you preeclampsia and premature delivery, and patients who have any conditions such as peripartum cardiomyopathy, which is where the heart muscle significantly impacts by the pregnancy itself, those patients are more prone to a few years down the line, but increased cardiovascular risk, because the whole condition actually inflames the lining of the coronary arteries, the arteries that supply blood to the heart muscle itself. And this may not impact immediately at the time of the delivery, thank goodness, but a few years down the line it produces increased cardiovascular risk, and that's something we should be addressing. So when I see my patients in clinic, I always ask about their pregnancy stories. Like, did they have preeclampsia? Did they have any complications? Because that means that then 10, 20, 30 years down the line, they may end up with a heart attack which isn't explained and understood. But the reason why is because of this stress that's happened in that pregnancy-related complication. So it's definitely worth, recognising this needs to be supported and addressed going forward.
So it really isn't just a transient thing that's present during pregnancy and then has no effect afterwards. There's a long term.
Ongoing.
Yeah,
absolutely. Yeah, so there's a lot of misinformation about cardiac symptoms in women. There was a feeling many years ago that women got atypical symptoms. That's what we were labelled as, atypical chest pain. But actually, when you take a history and actually listen carefully, you hear that actually patients are saying the same thing. Women may often sometimes also complain of fatigue and dizzy spells and other additional symptoms, but generally the symptom is, say for heart disease, in terms of coronary artery disease, is a chest pain, is a deep, heavy, central chest pain that happens when people are exerting themselves. So a pain that's reproducible with exertion is usually indicative of something significant. Sometimes women present to other people, sometimes to dentists, sometimes to orthopaedic surgeons with shoulder pain or jaw pain, but actually taking the history and actually listening to the patient, which is what we're finding is a real problem when dealing with women and our female patients. We all need to listen better. But actually when you listen, you hear that the symptoms are breathlessness, chest pain, sometimes palpitations or funny heartbeats when you're actually walking or exerting yourself or pushing yourself. So these things need to be listened to, and people need to be aware of these symptoms to look out for, so that then they action them by actually seeking some medical help. Coming to your great GP, getting assessed and then getting referred appropriately.
I wonder if somebody has more of a sedentary lifestyle and so there's less exertion. Are there any any other ways of actually acknowledging what those symptoms could be? Well, simply walking upstairs or walking up, that would be enough exertion for that, yes.
Probably a little bit more than just picking up the remote control, but, going up the stairs or running for a bus or, there's usually something in somebody's life every day that they'll exert themselves somehow.
Yeah, thank you. So again, for you, Sushma, so in terms of this fertility and pregnancy-related complications, so awareness for women and organisations of the health risks associated with this period.
So Shrilla just described pregnancy as a biological stress test in so many ways. I think pregnancy and childbirth are possibly the most difficult thing a woman's body, and particularly her pelvic floor, has to go through in anyone's lifestyle. And it is directly correlated to what your BMI is, how big the baby that you're carrying in pregnancy is, how many you have, how you choose to deliver them. And you may not choose to have a difficult delivery, but I meant in mode of delivery, whether it's a vaginal birth, a section. People forget that even if, people often think having a cesarean section is the easy option, but it is not to a large extent, because the physical pressure of carrying another human being and carrying that person for 9 months puts a tremendous amount of pressure on the pelvic floor. Thereafter, the vaginal birth itself, where, we talk about a large object coming through a narrow passage, such that both the object and the passage remain, is a difficult process. And women at that point, I feel, again, are simply just not well informed. So you have all sorts of reasons why women during pregnancy and in the immediate postpartum period have prolapse symptoms, have urinary incontinence, have pain, have discharge, and once again are often not listened to. I think this is a common theme that we are going over, because everybody says that it's just after delivery, it will become okay, and possibly it will. But that woman merits a proper hearing. Somebody should listen, examine somebody who knows what they're talking about, and then reassure. You cannot reassure somebody if you don't know what is wrong with them. Yes. How have you offered this reassurance? These are real problems, and they have real solutions, which need not be deferred just because someone is pregnant or is immediately postpartum. Admittedly, not all options are suitable for pregnancy or breastfeeding mums, but there are lots of things one can do. For example, seeing a physiotherapist. It's the single best thing a woman can do for herself. Seeing a physiotherapist while she's pregnant and then carrying on seeing a physiotherapist after. And yet very few women are aware of this. All breastfeeding women, in my opinion, should have vaginal estrogens, and hardly anyone ever is, because pregnancy and breastfeeding are very hypoestrogenic times in our life, and our bladders and vaginas don't like that. So a lot of the symptoms could be mitigated to a large extent with vaginal estrogen. And yet that is not a commonly known thing. I distribute this like sweeties in my clinic on a weekly basis. And women almost look at me and say, well, why didn't anybody tell me? It's because people either don't inform themselves or don't educate the people that we are meant to be helping. So I would say these are very, very common things. Then, of course, there's the actual birth, which leads sometimes to tears, third-degree tears, fecal problems. So women are soiling themselves and they are shocked, they are embarrassed, often ashamed, as though in some way it is their fault. They don't talk about it. And when they talk about it, if they get dismissed, they almost never talk about it again. And this has long-lasting effects then and later on when they actually become menopausal, because there's damage then that wasn't addressed. Postmenopausally, when tissues lose their natural resilience, these things become a very big problem. For example, there is good evidence now that if you have forceps delivery, you are 20 more times more likely to need surgery for prolapse in your life. If you have a 1-2 delivery,
times.
20.
Wow.
If you have a 1-2, that's about 7 times. The genital hiatus from where we deliver babies expands by 200% when women have vaginal birth. So the fact that it's only 20 and 7% is actually a testament to how well we are made. So I think there are lots of issues here. And obviously, women have already taken some time out for mat leave, then they feel ashamed, as though it's their fault for not being well, in extending the sick leave to deal with these problems. So I think here is a real role for companies to have an open culture, to make sure they have their in-house GPs to assess these problems, because there are solutions. So I think people are moving in the right direction, but there is so much more one can do.
Yeah, I'm really quite impressed to hear that there are so many solutions, because oftentimes walking around a grocery store and just seeing sanitary pads for urinary incontinence, I'm like, surely that can't be the answer. That's what we all are going to anticipate.
The number of time my son has to physically restrain me from throwing something at the television when I see that advertisement which says, oh, girls, let's go out for a night out. Let's all just put on our pads.
It can't be the answer.
That cannot be the answer. You may choose it to be an answer. That's your choice. But that is not the only answer. So thank you for bringing that up.
Yeah. So as women, so I think also in relation to what you mentioned, so something I've never heard before with that statement that you made, Sushma, about your consideration that all women pregnancy and lactation should be given vaginal estrogen. I'd never heard anybody say that, so thank you for sharing that. And I think in terms of considering big hormonal transitionary points, so as many women move beyond pregnancy and fertility concerns, many begin to experience the hormonal transition into menopause. And this is an aspect of women's health that is being discussed more than ever, but there are still many, many misconceptions. So from your perspective, what should people really understand about this stage of women's health?
So menopause is a huge transition, and luckily there's a lot more information out there than there previously was. I think the most important thing is awareness. So the more you know about it, the more you can be armed and ready. And for all of us as women, we're all going to go through it. So we can't just put our head in the sand. The healthier you are going into menopause, and the better your sort of general lifestyle management with diet and exercise and stress management, the easier your menopause journey will be. We know menopause age of onset is 45 to 55 years of age, but actually individuals start to develop perimenopausal symptoms much earlier. So from their early 40s or even late 30s, as estrogen levels start to drop, you can have subtle symptoms. Mood-related changes, irritability, anxiety, brain fog. You're just not coping as well as you were previously coping with normal daily life. And I think this is the most common presentation I see in my practice. A woman, 45, top of her game, busy, work and home life, teenage children, aging parents. It's not easy. But she managed fine a few years ago, and all of a sudden she's just not coping. And people come in with what they describe as burnout. And as soon as someone says burnout, I think this is probably hormones at play. We know that the hot flushes, the night sweats, and the insomnia are associated with menopause, but there are so many other symptoms that it can cause. And what people don't realize is the long-term consequence. So after menopause, you are 5 times more likely to have a cardiovascular event because of the impact of the drop in estrogen on your cardiovascular system. And 1 in 2, so that's half of all of us women, are going to end up with osteoporosis because estrogen is so important for your bone density. So these are things that as women we need to work hard towards improving so that long term we don't end up with risk factors.
Those are some statistics. And would you like to refer?
Yeah, I mean, following on from Jane's excellent points there, up to 40% of a woman's life can be postmenopausal. So it's really an important section of her life that we really need to address. And the cardiovascular risk is massive. From very low risk, losing the estrogens increases our cardiovascular risk massively, hugely. And part of that is the impact it has on our bodies. We gain weight, our blood pressure goes up, our bad cholesterol goes up. So we lose so much of the protective effects of having those estrogen hormones that we've had all those years. And it really impacts on us quite significantly. And the loss of those hormones actually accelerates and weathers the cells that are remaining in our bodies. So actually it causes accelerated vascular aging. So it causes our blood vessels to become stiffer and less responsive, and then that impacts on blood pressure. And with the increased weight gain that we get with postmenopause, it causes a thing called metabolic syndrome, which then causes pre-diabetes, diabetes, high blood pressure again, and also coronary artery disease and a thing called atrial fibrillation, which is an irregular pulse of the heart, and that predisposes us to stroke. So it's a real unwind of our system. So we really need to patch it all back together again and actually address our cardiovascular risk. So when people are in that peri and postmenopausal phase of life in our working lives, because that will still be, most people will still be working at that point, we need our organisations to be offering really good screening. Taking a blood pressure doesn't take a few minutes. It just take a blood pressure in a quiet room, take it properly. Check the cholesterol, check the pre-diabetic status, and also give some lifestyle advice as well. So try and support our patients, because this is a huge stress. And we know that stresses like this can impact on cardiovascular disease events and increases cardiovascular disease events by about 40% to have a lifestyle stress like this.
Yeah, and I just wanted to make a point about when you said about weight gain, it's not necessarily all over the body. It can be just literally around the middle of the body. And so even if we're using things to disguise that, that's still in and of itself a point of a consideration for us to explore. So,
and that weight gain around the middle actually reflects a thing called visceral adiposity. And basically that means that we're coating our internal organs, the pancreas, the liver, the heart, the kidneys, with an inflammatory white-yellow fat. And what that does, it seeps chemicals into those organs and causes dysfunction of those organs. So actually we really, really do need to, so that creeping weight gain that we all say, oh, is midlife and we all accept, we shouldn't accept, because it basically is contributing to our ongoing increased cardiovascular risk.
Thank you for clarifying. Please.
Moving on from those events, a little bit later on, even if women are on, even if they are on systemic HRT, what again I find with my hat as a urogynecologist is now a woman who is the boss in her career. She's worked hard, she's reached the top of the line, she's been fit and well, she's looked after herself and everything. Suddenly her life is now blighted with recurrent cystitis. Now we talk about this in a quaint way, we call it honeymoon cystitis, which is I think a god-awful name anyway to start with, but we have a resurgence in this. Women are coming to me and saying, what is wrong with my vagina? I feel like I'm sitting on a cactus. I can't do that. I have back-to-back meetings. I have meetings in Hong Kong, Singapore, different time zone. And all I want to do is rub out and put ice cubes in. And that is real women telling me these things, right? It is because even if you are on systemic HRT, very often the two organs that really suffer, about 5-10 years on a rough average after the menopause are the bladder and the vagina. The linings of both these organs are very estrogen dependent. And when you don't have the levels of estrogen as one ought to, they complain loudly, bitterly. And you either actually get infections because the thickness of the lining of the bladder, for example, is the most important defense mechanism against bugs. Or even in the absence of infections, the bladder is perpetually inflamed. So women go nuts. They think, I'm really losing my mind. I have every symptom of a UTI. My GP says the urine culture was negative. And all they needed was some vaginal estrogen. And that will really make a big difference. So that is the one thing. The second thing at this time is, A, this is happening, and 2, women's testosterone levels fall off a cliff, and therefore so does libido very often. And when you combine loss of libido with a dry vagina, that is putting an end to women's sexual health, which is, they're young prime women. That's an awful thing. It's an awful thing for them. It takes a big toll on relationships. That in turn adds to all the mental angst, and then you can't focus on what you're already very, very good at and have worked so hard to get to. So I think this is where, again, awareness is really important, that these can be fixed very easily. There is vaginal estrogen, there's a combination of estrogen and testosterone, or there's systemic testosterone that we can give women as well. Then there's, of course, a small subset of women who've had breast cancer. These women just believe, because that's what they've read, that they cannot have any form of estrogen, and that is so blatantly not true. I deal with a lot of women with breast cancer, and the vast majority of them can still have vaginal estrogen, not systemic estrogen, but vaginal estrogen. So there are options. For women who cannot have systemic estrogen, if their lives are plagued by hot flushes, they can have non-hormonal systemic treatments called Veoza, for example, is a tablet that you take. Most women can have it, and their hot flushes are controlled. So there are lots of options that exist, and all you need is to go to someone who does this all the time. So if your company has the right environment for you to raise it with, say, your line manager, who then says, well, there's an in-house GP service, you raise it there. If it's something they can deal with, they will deal with it there. If they think you need a referral, you will come in and have it done. But I think that's a really important thing. So these are important considerations.
So what I'm hearing consistently is that we need more awareness about these issues so we can identify, but also I'm feeling really encouraged to recognize that there are actually lots and lots of solutions that that are available for us. And so if we're moving along, that's keeping in theme with what you actually mentioned earlier, Jane, around bone health postmenopausally. So osteoporosis is a condition which usually emerges in that postmenopausal period, but it's actually determined much earlier in life. So why is osteoporosis such an important but often overlooked part of women's health?
So as women, we need to be building our bone strength in our 20s and 30s, because as soon as the estrogen levels start to drop, we get a reduction in bone density. With menopause, we get something called musculoskeletal syndrome of menopause, and this is often not talked about. This is a combination of various symptoms related to the drop of estrogen, specifically reduced bone density, reduced muscle mass. You can get inflammation within the muscle, tendinitis. Often my patients will come in for a menopause consultation. I'll see them for a follow-up a few weeks later and I'll say, how are you? They'll be like, oh, the HRT was brilliant, but actually my frozen shoulder is so much better. And they didn't even tell me about the frozen shoulder to start with, because you get this adhesive capsulitis where everything just gets a little bit tight and uncomfortable. And actually normalizing the estrogen can improve these symptoms. So when we are young, we need to be optimizing our diet and lifestyle, making sure that we are doing weight-bearing exercise, so important. Something against resistance, whether it's actually lifting weights or Pilates or walking uphill, but anything against resistance can help. And we need to make sure that the building blocks of bones are there. One is calcium. Our oral calcium that we take in needs to be sufficient. If it's not, what happens is we just end up sucking the calcium out the bones to keep the blood levels normal. And my patients will often come in and say to me, oh, but I don't need to worry about calcium, my blood levels are normal. And I'll say, they'll always be normal unless you have a weird and wonderful endocrine disorder, which is extremely rare. And that's because we have this amazing metabolic pathway where the blood levels maintain, by correcting themselves through removing calcium from the bones. Vitamin D, in the Northern Hemisphere, we should all be on a vitamin D supplement. The World Health Organization tells us about 400 international units over winter and 1,000 over winter and 400 over summer. But that's an important building block. And I can't tell you how few patients are actually on vitamin D supplements. And they come for health screens and we tell them that their vitamin D levels are low. And I'll see patients a year later and I'll say, are you still on the supplements I prescribed for you? And they'll say, oh, I took it for a few weeks, but I stopped. So it's about making sure that we build these different aspects of well-being into our lifestyle so it becomes normal. But bone density is really important. The other thing is that getting a DEXA scan to assess what your bone density is really difficult because most medical insurances don't cover it. So that means individuals are self-funding. You need to have had a fracture in order to get it covered through insurance. Whereas other countries, individuals would get a baseline DEXA scan as they enter the menopause, so they are aware of different options available to improve their bone density.
Thank you, Jane. Is there anything that you would like to add in terms of osteoporosis or no?
Just reiterate the exercise
Go
and
see Jane.
lifestyle.
Yeah, yes, go see.
I think, one thing just to add to sort of this menopause transition and the menopause journey and women's health in general is the huge impact on the mental health. And through every stage in a woman's life, how we should be optimizing general well-being, but also accessing help that's out there. And I know that so many employers these days have mental health first aiders, on-site psychologists, and just so much support. So as women, it's about making sure that we prioritize our well-being and take the time out to actually get the help we need. We know that through menopause, one of the treatment strategies is actually cognitive behavioral therapy. And we're lucky enough to have a team of women's health therapists that support our practice. But through every stage, it's important to be aware and get the help that you need.
So we've covered a huge range of issues today, and we really only scratched the surface of women's health. So given that many conditions are still misdiagnosed or diagnosed late, how can women better advocate for their own health, and what role can employers play in helping people access the right support earlier?
So I think as a woman, we need to be proactive. And the more information we have, the better we can take ownership of our health. So from an employer's perspective, making sure individuals have access to right and relevant information. So education events like this, increasing health awareness in the workplace are so important. And then also looking at your individual sort of health screening program. Does it correctly address women's health needs? Making sure that you have access to the right psychological services to improve sort of the mental health aspects that women go through. And just having a workplace where the culture is such that you can come forward and speak about things without fear.
Yeah, I agree with those. Sorry,
No, go.
I agree with everything you've just said. It's really important to have an open culture in every organisation that allows us to accept that women have different stresses to men. So from early life, from starting periods to pregnancy to menopause, these are stresses in life that increase cardiovascular disease risk going forward, but they're stresses that are unique to women. And actually, as a result, organisations should have support networks and peer group support where we actually provide some sort of in-house or local support from people that have been through similar situations. We also need to have access to better health assessments, easy access to health assessments, and access to health improving behaviours. So gyms, gym membership, yoga, meditation, quiet areas, so places where people can go to de-stress. The final thing we should also talk about is how men can help in this, because allyship is really, really important. Wonderful. It is a women's problem, but it is a problem that impacts everybody in the workforce. So if you're female co-worker is struggling with something, it may well impact on a male co-worker in terms of impacting on their workload or their day-to-day stresses or their work environment. So actually it's really beneficial to everybody to address women's health issues. So organisations definitely need to be addressing this going forward, because a healthier workforce is a healthier workforce for all.
Yeah.
And
Absolutely.
just to add to that, I think what's interesting, because we do a lot of menopause manager training, and as soon as we speak about an open environment where people can come forward, as a male manager, people feel fearful. And it's not about going to an individual and saying, oh, I think these symptoms might be menopause related. That might not go down well. But it's about noticing that someone in your team has a higher rate of sickness absence, that they don't seem themselves, that they may be not attending sort of your group events that they would normally attend, and saying to them, do you know we have access to an employer assist program? Do you want to maybe take some time off to see your doctor? And signpost them in the right direction. So you don't need to necessarily speak about what you may think the concerns are, but it's just about being supportive, knowing what your company has and signposting correctly. And then also from an employer sort of company perspective, it's looking at what supportive policies there are in place. So menopause policy, mental health policy, maternity leave, parental leave, support for miscarriage, all of these sort of things make the environment much better for women to thrive in.
Was interestingly, Jane, just to take it from there, I was talking to somebody yesterday and they said to me, we need a AAA attitude. And I said, what is the AAA attitude? And I thought that summed it really well, which was that what we need is awareness, both self-awareness and awareness that is promoted by the workplace. We need access to primary care, a second opinion or tertiary care, and we need attitude, the right attitude at work, at home, in every aspect of your life. There's nothing that we must shy away from discussing or speaking openly about. So I think that actually just summed that up very well.
Awareness, access and attitude. Yeah, wonderful. So given that many of these health conditions affect women their busiest years of their working lives, what practical steps, I think you've already mentioned some of them, but what other practical steps should organisations take, both in terms of support and culture, to better enable women to manage their health at work? So Shrilla, you mentioned before about health promoting services, and I'd invite you all if there's anything else too.
So I think just to add to that, working women are busy and they don't have time. So the easier it is for them to access services, the more likely it is for them to get help. So when we see companies that have on-site services, so easy access to a doctor, a nurse, a psychologist, a physiotherapist, it makes it much easier. Also, occupational health can be a really good way of helping individuals who might be struggling at work come forward and get the right help they need, because this gives them an objective opinion from sort of to the workplace, but also it will make sure that that woman is addressing all the different areas that they need to address. From an individual workplace perspective, and we often give this advice in occupational health, simple things can make big differences. Having a fan on your desk if you're suffering with hot flashes, making sure that you have access to cool water, that the bathroom facilities are usable and easily accessible. These are really tiny, basic things that can make a huge difference in an individual's lives. If you're struggling with insomnia related to menopause, then possibly looking at some flexible working arrangement, if your company can accommodate, and then commuting out of rush hour can also really improve. If you think that you get awful hot flashes while you're on the train, if it allows you to get a seat, have a bit of space, it can make a big difference. So they're practical things.
I'm going to add one thing to that. When you talked about accessible toilets, there are these flashcards keys available. I'm sure companies can get hold of these. Women have little cards which says, I have a bladder condition, so in case they need to jump a queue. It's not that they're jumping a queue, they have something to show somebody.
Yes.
And there are these radar keys that you can tap on disabled toilets which are locked in, that can make a difference between thinking, oh my God, I'm going to wet myself, to wetting yourself, which is a hideous thing at any time, but on your way to work. So these are simple things which make such a difference to women.
Great.
And probably from the cardiovascular disease perspective, we mentioned already that having access to having a blood pressure check, it's not really expensive to have a blood pressure machine sitting in a room somewhere quietly. And then obviously access to blood tests, really, just to check on a yearly basis, perimenopause, what your cholesterol is, what your pre-diabetic status is, and then also weigh-ins as well. Know your BMI, because actually often you don't realise that, as perhaps a South Asian person, my BMI should be lower. And so as a result, even what my BMI may be in the standard scales may be acceptable, it may be in the obese range or overweight range. So just knowing those sort of things, it's just data, isn't it, really?
Thank you. So let's see if there are any questions. So we have, yes, a couple. I read yesterday that PCOS has been renamed to remove the emphasis from cysts which aren't necessarily present. Is this right?
Yes.
Yes.
Absolutely. Well done. It is. There is a move, and there's a 3-year transition now to call it PMOS. So PCOS, or PCOS as a lot of people refer to it, is polycystic ovarian syndrome. And there's been a struggle over many years to try and move away from this terminology, because it suggests that to have this condition, you must have multiple cysts on your ovaries. First of all, they're not cysts, but that's a different topic for another day. But they look cystic. So, for example, somebody's ovaries can look polycystic, but that doesn't mean they have the polycystic ovarian syndrome. So it's hugely confusing. So there's been massive campaigning from the Royal College, from the specialist groups, and from patients to change the terminology. And yesterday, and it's been accepted in many splinter groups, but there was no overall consensus. Now there is a consensus that we will move to calling it PMOS, which is polyendocrine metabolic ovarian syndrome. I think that is the full form. To move away from any suggestion that you must have cysts on your ovaries to have this condition, because it is a far-ranging condition with insulin resistance, cardiac implications, implications on the menopause, generally overall implications on your heart, on your joints, on your skin, on insulin. So there's a lot of implications.
So the metabolic and systemic effects are much more pronounced than the actual presence of cysts.
I mean, you may have cysts in the ovary, but that is not a criterion for diagnosis. That is why it is removed from the terminology.
Okay, thank you. Thank you so much for clarifying. How do I encourage my wife to take the time to engage with her health and well-being? She focuses so much on everyone else but her. I think that's probably a common state.
This is a great question.
Yeah,
that's such a sweet thing to say.
Yeah.
You know what? We see this so commonly, especially in our health screening, that people don't come forward with problems that have been there for a long period of time. And as women, we owe it to ourselves that if there's something wrong, we should go and get help. I always say to my patients, you can't be a carer for everyone else unless you are healthy and well. So take the time out and make sure that you are getting the support. In some extreme cases, I end up referring patients to one of our psychology colleagues for additional support, especially if this is a trend with regards to struggling to put boundaries in place to optimize your own well-being. Sometimes a few sessions with a psychologist can make a huge difference. But for most of us, it's just about making sure that we're taking the time out and prioritizing ourselves.
Yeah, thank you.
So, when you're going away on a flight and they say sometimes the air pressure will drop and the oxygen mask will drop from the ceiling. And they say, please place your own mask before you place it on anybody else. And that's exactly what we should be saying to that gentleman's wife. If she's not well, she can't look after everybody else. And actually, that's just a very selfish way of looking at it. But actually, that's what you could say to her. She needs to be healthy so that she can make sure everyone else is healthy.
Yeah, thank you. And is there a healthy way to delay perimenopause and menopause?
So what we do know is the healthier you are going into menopause or into perimenopause, the easier your journey will be. You may not be able to delay the actual menopause date. Often that is predetermined, and we often say to patients, chat to your mum, find out how old she was when she went through menopause, because you'll have a similar menopause transition. But we know that if you're healthy and well and exercising and eating well and managing your stress well, that actually you are likely to have an easier menopause. Stress and menopause are probably the biggest factors that don't go well together. As soon as stress levels increase, cortisol goes up, and cortisol has this metabolic pathway where it actually mops up estrogen in the body, so it's dropping your estrogen levels. So during times of high stress, what we see is that women may present with perimenopausal symptoms earlier, they may have worsening perimenopausal symptoms, or individuals who are on the most perfect HRT regime, as soon as stress levels peak, all their symptoms come back. So stress management is so important, and I speak about this at all of the talks I give. As women, we need to find a way of managing this, whether it's exercise, meditation, mindfulness, journaling, but we've got to find something to help optimize or minimize our stress as much as possible.
Wonderful. Thank you, Jane. That's a really clear response. Thank you for an excellent discussion. Thank you all for an excellent discussion. I want to ask the panel about their thoughts about whether AI can assist or impede women's health overall. What are the challenges?
It is capable of assisting, but currently I think it is impeding in a large extent because it is unregulated. Now, I'm not an expert on AI. I have no way of knowing whether AI can be regulated or not, but I think that the challenges are any kind of AI, if the base from which it is gathering data is limited to genuine, actual medical sources, where there are fact and not somebody's point of view or fiction that is picking up this from, because as I see it, AI kind of collates all the information out there. So if there is a way in which AI can collate information from reputable sources, then I'm sure it can assist women's health, because it will help in women being aware and being able to quickly look up something. But the minute there is no control, it's like everything on the internet. It can be your best friend or your worst enemy.
Absolutely.
So I think that is both its benefit and its challenge.
Thank you. So whatever platform effectively we want good, medical advice from medical sources. So in today's discussion, we've highlighted that women's health is not a series of isolated issues, but a continuum that evolves across a woman's life. Before we close, I'd just like to ask, and we've literally just got a couple of moments, I'd like to ask each of our panelists to leave the audience with one key takeaway. If there is one action that individuals or organisations could take to better support women's health, what would that be? Shrilla.
So, that's a great question. Know your numbers. So know your cholesterol, know your blood pressure, know your blood sugar levels, and know your targets. So what should they be?
Wonderful. Sushma.
As a gynecologist, I'm going to say know your vagina. No one is telling you something is wrong, then it's right. Just get the right help.
Wonderful. Thank you, Jane.
And as a GP, I would say know your potential. Make sure that you see your doctor, have your health screen, and just optimize your well-being as best you can.
Wonderful. Thank you so much. Thank you to all of our wonderful panelists for sharing their expertise, and to everyone joining us today. We hope today's discussion has helped highlight both the challenges and the opportunities when it comes to supporting women's health for individuals and for organisations alike.